So consensus development, so we'll talk about, molecular targeted imaging. So I divided the kind of discussion into kind of where the areas where I think there's stuff we know, where the future is going. So as we know, for newly diagnosed prostate cancer, PSMA PET's approved in the unfavorable, intermediate, and high risk group. But I think that, our session really focused on what's the future. And there's clearly a potential role for PSMA PET in detection of primary or secondary tumors in patients who have a negative or equivocal MRI. That's what the primary 2 study is looking at. And that potentially may reduce unnecessary biopsies in patients who have PIRA 3 lesions and also improve detection in patients who have a negative MRI with high suspicion. I think PET will also be increasingly used for PET-targeted biopsy, similar to what we do with MRI fusion biopsy. The role of PET for determining disease extent and eligibility for focal therapy, I think, is an area of great promise, and I think we'll be hearing more about that. And then, as I talked about a little bit in my session, PSMA is also provides potentially some biological information, and much work needs to be done to determine if that can be used for predicting response to different therapies, perhaps for selecting radiation versus surgery in certain cases. And then I think a really exciting area is using PSMA or other targeted either fluorescence guidance or radio guidance for surgical resection to reduce positive margins, improve the ability to detect and resect involved nodes, and to do nerve sparing where it's appropriate and not do it where it's inappropriate, so improving, hopefully, functional outcomes as well. In the case of recurrent disease, this is already an approved use, obviously, but many questions remain on how do we use this information? Can we extrapolate PSMA data to what we did beforehand? Should we stop doing surgery in men who, by PSMA, have a node where that's positive, where in the past we would have done that without knowing that it was existent? We had a long discussion about how to manage men who have oligometastatic disease. How many METs, how many nodes, what's oligometastatic, what's the appropriate treatment, how many should be treated, et cetera. So I think a lot of work, a lot of trials already ongoing in the space, and I think we'll learn more. And a big question always remains, should we wait for PET detectable lesions to be identified before deciding on salvage radiation therapy? I think hopefully new PET tracers may improve detection at even earlier time points with even smaller amounts of disease, perhaps helping us address that. And so that's why I put need for more sensitive tracers. We've gotten really good, but there's still a long way to go. In terms of treatment response and monitoring, I think PET imaging has a significant role to play, particularly in areas like focal therapy and radiation therapy, where perhaps in the case of focal therapy, there's no agreed upon definition of recurrence-free survival or recurrence. The field is all over the map. There are a lot of, like in the UK, they're focused on salvage therapy, radical treatment-free survival. That is completely, a made-up, endpoint, not validated, not really useful in clinical trials. Who determines who gets salvage, surgery or radiation versus not? Completely undefined. So we need better response criteria. So I think PET may be useful for this, both for short-term and monitoring long-term recurrence-free survival. The case of radiation, we talked about a little bit the other day. Our current definitions perhaps are so stringent that a large percentage of patients have incurable disease by the time they're actually diagnosed as having radiation recurrence. Maybe PET can be used for earlier monitoring and biopsy detection. And then, of course, in the case of advanced disease, can PET be used to determine response, particularly in cases where there's heterogeneous responses? Can you identify lesions that are resistant and perhaps treat them with radiation? So I think there's a lot of promise for identifying either oligo-resistant or oligo-recurrent disease. There's a lot of excitement about new agents, and I think we'll be seeing more. We heard about Clarity's agent that's already in clinical trials. We heard a lot about antibodies and minibodies and other protein structures that might be useful for detecting PSMA that perhaps have greater sensitivity, perhaps less bladder excretion, like posluma, but perhaps even less so. But we can't forget there are many other targets in prostate cancer. It's a target-rich cancer compared to many others. STEAP1 and STEAP2, there's a tremendous amount of interest. Actually, it's probably expressed more highly than PSMA and more homogeneously. PSCA, which is near and dear to my heart since I cloned it many years ago. A lot of interest in that, but other targets as well. In the case of neuroendocrine or lineage plastic neuroendocrine prostate cancer, there are really exciting targets like DLL3, and this is both for diagnosis but also for therapy, and we can't forget the role of FDG PET. In the case of, we didn't talk too much about Theranostics, but clearly, the future roles for PSMA radioligand therapy is something we discussed. Like every other therapy in every malignancy, we start at the end stage of disease and we move things earlier and earlier. What the role for PSMA radioligand therapy will be in the pre-chemo, hormone-sensitive prostate cancer, adjuvant, neoadjuvant space remains to be determined. Because PSMA is an androgen-regulated protein, can it be used successfully together with ADT in patients with hormone-sensitive prostate cancer remains to be determined. Of course, again, additional PSMA ligands. We heard a lot about additional isotopes today. Lead, copper, many different types of alpha particles are being explored, as we heard a little bit this morning. And then again, additional targets, STEAP1 and STEAP2, HK2 is being developed by J&J, PSCA, DLL3, TROP2 is highly expressed in prostate cancer, and sacituzumab is already approved in bladder. Of course, we can't forget that these targets can be targeted by more than just radioligand therapy, but also ADCs like enfortumab. Bispecifics are really exciting, and of course, even CAR T cells are being explored therapeutically against all of these targets. So I think that's where I'm going to end my summary. A lot of excitement in this field. We really just scratched the surface of where this is going.